You, Linda-Gail.
Thanks, Yaku. Hi, Dr. Fauci. Nice to see you.
Hi, Linda-Gail. It's such a pleasure. I miss you. We haven't seen you in so long.
Agreed. And I feel the same way. We've missed seeing Bethesda even at this stage. Lovely to have you, Tony. So good evening to all. And thanks to PPS and Medical Brief for hosting us here today. I am Linda-Gail Bekker from the Desmond Tutu HIV Center and the Desmond Tutu Health Foundation in Cape Town, South Africa. Today, it is my great pleasure and honor to chat to someone who's considered a critical scientific leader, not only in the United States from whence he hails, but literally worldwide. And here in South Africa, he's considered not only a very important scientific authority, but a very good friend. Dr. Anthony Fauci started at the National Institutes of Health in 1984 and has been a director of the Institute of Allergies and Infectious Diseases. He is very well known to anyone and everyone in HIV, but is now also a household name in the COVID-19 era. He served no less than 6 United States presidents, including the present, and advised US and global policy through all the infectious epidemics in the last 4 decades. Tony, welcome. Welcome to see you. It's such a pleasure. And thanks again for squeezing us into your really busy schedule. This is a week that I hope we will be launching Ensemble, the COVID-19 vaccine trial here in South Africa. So since our time is limited, I thought we could concentrate on all things COVID-19 prevention. So before we kick off on that conversation, I thought we would just maybe share some impressions. We've learned a lot about SARS-CoV-2 in the last 10 months. What would you say has been the most surprising about this epidemic and specifically this virus, SARS-CoV-2, compared to some of the others that you've dealt with in the last 30 odd years?
Well, Linda-Gail, good question. And there are a couple of points that have been prevalent in my mind as we've experienced this extraordinary journey we've all gone throughout the world over the last 9 or 10 months. The first is the incredible efficiency with which this virus can spread from person to person. You know, we often talk about our worst nightmare is a virus that jumps species, has a high degree of transmissibility by the respiratory route, and has the potential to have a high degree of morbidity and mortality. It's kind of like the worst case scenario. And that's what we're seeing, unfortunately, with this virus. The other thing that is notable, but also puzzling and makes it very difficult to message. I know it's difficult here in the United States, and I'm wondering what your impression is in South Africa. I've never, as you know, Linda-Gail, I've been chasing viruses now for 36 years as director of this institute. And I have seen a variety of things. You and I both have been knee deep in HIV/AIDS. This is so different because the spectrum of disease from 40% of the people who have no symptoms to those who have symptoms, 80% have mild symptoms. And then you have 15 to 20, 25% who have severe or critical involvement, leading to the high degree of morbidity and mortality. So when you have such a wide spectrum, some people, particularly young people, feel, oh, this isn't going to bother me. I mean, most of the people in my age do very well, they recover and they're fine. In the meanwhile, this virus has killed well over 1 million people worldwide and 225,000 people in the United States. And when you try to get a message that this is really something really serious, it's historic in its seriousness, there are still people who don't take it seriously. Hence, the great disparity in the United States about following simple, fundamental public health guidelines, like wearing a mask, physical distance, avoiding crowds. We still see segments of our country that don't do that. And that's the reason why, as you probably know, over the weekend, we had the highest number of daily cases since the beginning, 83,000 cases in one day. That is terrible, Linda-Gail. That I've never seen anything like that.
Yeah, and we obviously have been watching with horror from here. It has, I think you're right, Tony, it has raised for me a lot of questions around parallels with HIV. And the one that sort of occurred to me is how hard it is to message this sort of complete prevention of contact between susceptibles and those who are infectious. And it raised for me, we had to move to safer sex as opposed to, abstinence, which really became an impossible message. And so the thought I've had is maybe we need to be thinking about safer socialization or safer breathing rather than, this sort of message that we can somehow prevent infection completely. What do you think about that?
Oh, Linda-Gail, you hit the nail right on the head. In fact, this is it's amazing that our thoughts are right on the same line. I have been essentially preaching here that we've got to get away from the mentality of either shutting down completely or to hell with it, do anything you want to do without any precautions. It's the same way back in the day of HIV when we would say, just say no to drugs or no sex at all. It doesn't work that way. We don't want to shut down the country and destroy the economy. But on the other hand, we don't want people to go and say there's no such a thing as public health measures. There needs to be things that allow you to safely and prudently open the country again. And those are the simple things that I just mentioned, the wearing of masks, the physical distance. You don't have to shut down your economy. You don't have to shut down your factories. You don't have to shut down all of the business things. You could still do that in a way that, as you say, safer way to operate as opposed to shutting down.
Yeah, and in this country now, we've had about 750,000 diagnosed cases and 19,000 deaths. We're still ahead on the continent, happily no longer in the top 5 worldwide. But clearly there have been differences in terms of, it would appear, in terms of the severity of the infection here in the South compared to what you guys have seen in the North. And I was just wondering, quite a few people asked me to ask you this, why you think things may have not sort of come to pass. I think there was huge doom and gloom about what could possibly go down in Africa. I wonder what you think about that.
Linda-Gail, I think there are probably a complexity of reasons for that. But one of the things that strikes me is that the United States is a very large country, and it's quite heterogeneous geographically, demographically, in so many different ways. We have this system of 50 states that have a degree of independence from the central government. When you have a pandemic that is involving the entire country, you can't have disparate responses where one state decides they want to do it one way, the other state the other way. Everybody's got to pull together. And in some countries, like South Africa, a smaller country, but nonetheless a country in which, in my impression, you can do things much more centrally. We've had situations, you may have seen it on the news, because I've heard from colleagues in South Africa that they heard us at the press conferences at the White House, where we would say, in order to open up the economy, we need to have a gateway, phase 1, phase 2, phase 3, where you gradually open up. The 50 different states did it 50 different ways, and it just didn't work. And that's the reason why we had that resurgence where our background never got below 20,000. Then it went up to 40,000, then 70, and then back down, and now up to 80. We're not pulling together as a unified country, whereas other countries, I believe, including South Africa, do it much more that way. That's what I think the difference is.
Yeah, and here, obviously, we're in what we now call lockdown 1, which means certain behaviors are still mandated, including the wearing of masks. So somebody did ask me to ask you, is it not time for the United States at least to mandate mask wearing, and wondered what you thought about that.
Well, I know you have better things to do than to watch CNN, Linda-Gail, but on Friday, when I was asked that by Aaron Burnett, I said exactly what you said. I said, if we can't accomplish voluntarily the uniform wearing of masks, then we really have to seriously consider mandating it, because we have certain sections, regions, cities of the country that just are not doing that. And if you look at the map of the United States, when you reach a certain level of increased cases, your county turns red. Our map is very disturbing now. There are many, many, many red spots on the map.
Yeah. So turning to vaccines, which really is the sort of hot topic of the day here now in South Africa, we've got at least 3 of the candidates either in phase 2, and as I say, we're about to start the big phase 3. You've said that you're hopeful we'll have a readout by Christmas. Do you want to just expand on that a little?
Sure. Yeah, definitely. So if you look at the United States is helping to subsidize, develop, facilitate the testing of 6 candidates. 5 of them now are already in phase 3 trial. 2 of them, Linda-Gail, the Moderna mRNA and the Pfizer mRNA and the AstraZeneca candidate, as well as the J&J, are now not too far behind. So the Moderna and the Pfizer started phase 3 on July 27th. And we figured by the time we get to the end of September, beginning of October, we were fully enrolled. And it's a prime boost on both of them with 28-day difference. So we should be collecting data right now. And remember, we're looking at the first interim look at 50 infections. We're going to be there soon. So the way the projection is that we will likely know by the middle of November whether or not we have a safe and effective vaccine, at least in those 2 candidates, with the others not too far behind. So looking at the initial phase 1 data, where it induced robust neutralizing antibodies to the level that is comparable to, if not better than, convalescent plasma, and so far, no really significant safety signals, I think we're going to get an answer probably by the middle of November. Given that we've already started producing at large amounts, doses enough to begin to start administering by the end of December, the beginning of January. So I think we're right on schedule.
So that really is good news, but it raises a couple more questions. So the one is, what vaccine efficacy do we feel is worthy of deployment? So that would be the one. And then I guess for public health benefit, we really need to look at coverage as, as the second big question. So just more thoughts on that.
Sure. Well, the trial is powered and designed to pick up 60% efficacy. I am hoping, Linda-Gail, that we get to 75%. I'd love to get like measles with 98%, but I don't think we'll get there. If we do, wonderful, I'll take it. But I think that that's unlikely. I'll be satisfied with about a 75% efficacy. That's the first thing. The issue of uptake is a particularly significant problem in the United States, because when you do surveys, particularly among the most vulnerable in our community, the most vulnerable, besides the elderly and those with underlying conditions, are the African Americans and the Latinx, which comprise 13% plus 18%. So you're talking about well over 30% of our population are minorities. And those are the ones that are suffering terribly. When you question them, particularly the African Americans, anywhere from 25 to 50% say they're either definitely don't want the vaccine or they're not sure that they want it. So it would be terrible if we do have a safe and effective vaccine, and yet the most vulnerable are not doing it. So we're doing what we did with HIV in the old treatment networks, the ACTG, the HPTN, the HVTN. we're using our community representatives to extend out to do community engagement to convince people why it's important to both participate in the clinical trial and when the vaccine is available to actually take the vaccine. It's not going to be easy. There's a lot of skepticism in our community.
And these first generation vaccines are all focusing on the spike protein, right? So if we do get, say, moderate, if we're not as optimistic, efficacy, what will the implications be for the testing of the second generation? Have we sort of thought through a plan for that as a possibility?
Yes, we certainly are. I mean, we have a number of candidates. Everybody's focusing on what's in advanced trials. We have multiple candidates of other targets that are already beginning to be developed or in early phase 1. So I believe that we're not going to stop. We're going to try and get the best possible combination. And since this is going to be, as you well know, as well or better than anybody, since this is a truly global pandemic, we're going to have enough vaccine for billions and billions of people, not just millions of people. So the more the merrier, and the more companies we can get in there, the better we'll be off.
Yeah, so I guess the thing I'm getting at is what we're struggling now with pre-exposure prophylaxis. We do away with the placebo arm, right? So then we pit one vaccine against the other, just to answer a number of questions that came up ahead of this.
Yeah, absolutely. Absolutely. I mean, I think ultimately we're going to have head-to-head comparisons. We're going to get the first core of, let's say moderately effective. I hope it's more than moderately, but let's say it's moderately. Then when vaccines come along, we're going to do what we've done with other infectious diseases. Just compare them. Maybe do it in a 3-part, and just have, non-inferiority or superiority trials. It's going to require a lot of enrollments, but that's okay. That's all right.
Yeah. Yeah. And the question that comes up is, and I've heard you say that the only thing we are risking is money, not safety, which I really like. And I think that's an important message to get out to everyone as we expedite and accelerate, development of these vaccines. We're worried in low and middle income countries about access. We had a bad experience with antiretrovirals. As you know, you played such an important role in PEPFAR and making sure we had better access to these life-saving treatments. What about life-saving vaccines? What is the feeling for countries such as South Africa in terms of access?
The same thing. I think we just have to draw the same parallel that we did with PEPFAR. I mean, George W. Bush's message to me that there's absolutely unacceptable, and we have a moral obligation to make sure that when we have life-saving interventions, that they are universally and uniformly available, not only to the countries that can afford it. And I believe as a global community, we need to make sure that we don't have just the rich countries getting it. And that's the reason why when we contract with these companies, we talk about billions of doses, not hundreds of millions of doses. So to me, it's a moral obligation, Linda. You know how I feel about that.
Yeah. So how do you actually see the deployment of the vaccine playing out? I mean, if we get an answer by Christmas, what are the next steps in terms of its actual deployment in your mind?
Well, in the United States, we have a couple of committees that you're probably familiar with it. The ultimate one is the Advisory Committee on Immunization Practices, which advises the CDC, which sets the prioritization. This year, given the seriousness of the situation, we took it one extra step. And the NIH and the CDC asked the National Academy of Medicine to also weigh in on what the right prioritization is. The National Academy has come out with their recommendation that first and foremost, healthcare providers that are on the front line to see COVID-19 patients, followed by those who have underlying conditions that clearly now have been associated with a poor outcome, followed by the elderly, followed by people with critical positions in the community, safety, keeping the trains running, keeping the electricity going, and then everybody else, all the healthy people. So hopefully, if we get the kind of success which I'm projecting and hoping that we will, by the time we get to the second or third quarter of this 2021, we will have it distributed. And I think the same thing should go globally also.
Okay, so that's obviously really exciting and, gives us a lot of hope. Just because there are always Cassandras anywhere, how do you think it plays out if we don't get, a successful go on the first round? What's in store for us?
What's in store for us, I believe, let's say we're into middle of 2021 and God forbid we don't have a good vaccine that we're even have available to even begin to do. I think we're going to have to, one, continue to carefully double down on public health measures so that we don't completely destroy the economy of the world. At the same time as put a lot of effort and investment into therapies that are not only for advanced patients, like with the dexamethasone and the people on ventilators, or the remdesivir with people requiring oxygen, but early treatment to keep people out of the hospital. And that, to me, would be things like monoclonal antibodies or targeted antiviral drugs. So we're doing that anyway, Linda-Gail. So it isn't as if we're slowing it down, trying to determine the success or failure of a vaccine. We're doing it anyway. But if it turns out that's the only tool we have, we're going to have to ratchet that up, because if we can't prevent the infections completely by public health measures, at least we can mitigate against hospitalization and death.
And obviously there are some other, I suppose, prophylactic options that might be out there. And so people have been, well, we're testing the non-specific vaccines here. So this notion of measles, mumps, rubella, BCG. I don't know what your thoughts are about that, sort of shaking up the innate immune system to see if it can do some good.
No, the answer is that has been proposed. We haven't led with that because we have some degree, I hope it's not unfounded, confidence that we'll do well with standard adaptive immunity vaccines as opposed to innate immunity vaccines like measles. And there was a proposal that in Russia during the time when they gave oral polio, there was a diminution in influenza because of the innate immunity. So we have our eye on that. That may be something we have to go to. I think that would be something that we'd have to seriously consider if we're not successful with the standard classic vaccinations.
The other one that Robin and I have been watching for a long time now is that vitamin D story. And I wondered what you thought about that, because I haven't seen any real randomized controlled trials taking us down that road.
Well, I have a deep down, non-scientifically based prejudice for vitamin D. And the reason I do, as a matter of fact, I'm not ashamed to admit, I take a few thousand units a day myself anyway. And the reason is that there are some really good studies that, Tom Frieden, who we both know well, Tom tells me that when he was in India and in Africa and we're looking at the differences in tuberculosis, morbidity, and mortality, there was a clear relationship to either the exposure to sun or to vitamin D levels. So to me, it's such a benign thing that we should be pursuing it. We haven't done the real randomized placebo-controlled trial because there's too many other things confounding it. But I think it's something that we should take seriously. Of all the non-traditional, non-specific things, I think that's something we should take seriously.
Yeah, and maybe something we could prescribe for healthcare workers, at least in the meantime, I imagine, as you say, and the elderly. So right. What is the chance that the vaccine, like influenza vaccine, doesn't work so well in, say, the elderly or those who have innate immune issues, as somebody asked me today?
You mean if the non-specific ones don't work in them? Is that what you're
No,
saying?
I'm actually thinking more about our specific COVID vaccines.
Yeah, then we may need to go to the non-specific. That to me, that would be something to be seriously considered. Because the evidence that innate immunity goes down as much or more than adaptive immunity, I'm not so sure about that. I don't think the study has been done of that. But you could run out of naive cells, and as you get older and older, to respond to new antigens, but you don't run out of macrophages and you don't run out of dendritic cells. So maybe that's the way to go.
Agreed. And then, I mean, what are the prospects of getting monoclonal antibodies out in large volume? Is that harder than a specific vaccine? Because obviously, as a prophylactic, that's another thought.
Yeah, I believe that if we put our resources to it, we could get companies. I mean, I know we could do it in the United States. I'm sure other rich countries could do it, to make monoclonal antibodies at doses that they can be prophylaxis. Sort of like an AMP trial for COVID, only we're doing it with an antibody against COVID and not against HIV.
So I see that our time is running out, and before it does, I wanted to end on a slightly more personal note, and my personal note really goes with huge thanks to you and Dr. Grady and the family, because I know that you've been through a lot, but I want to thank you for your leadership and just everything that you've meant to so many people through this epidemic. I'm very pleased that NAM and the NIH most recently have honored you with awards. And we know that there's a Tony Fauci bobblehead, and we think that that's really very good, as well as T-shirts and masks. But I wondered what, from your point of view, will be the most memorable thing of the last 10 months. It's been an extraordinary time in your life, I know, and it has for members of your family as well. But maybe on this Corona coaster, as it has been described, what sticks out to you as memorable? I just want to put in there that personally, the Brad Pitt impersonation would be mine. I'd love to hear what yours has been in the last 10 months.
Well, there's one that's serious, and there's one that's a little lighter, as it were. The serious one is and I know you've seen this in South Africa, the extraordinary bravery of the healthcare providers to throw themselves into this, and in a way that endangers themselves literally every single day. And we've seen that globally. We've seen that in the United States. We've seen that in South Africa. We've seen that in the European Union. And I think it just says a lot for our community of healthcare providers. And I'm really impressed with that. That's something that really impressed me. The other thing on a lighter side is the extraordinary surrealistic world that I'm in, where people are looking for something that represents truth, integrity, and clarity, so that they've picked me out because I'm visible. But it isn't really me, Tony, that Linda-Gail. It's what we all want. We all want truth. We all want science. We all want clarity. So I'm very impressed how the world is galvanized around the importance, when you have misinformation and you have deception on one hand, and then on the other hand, you have what we've lived our lives for, and namely truth and science, data, evidence. Those are the kind of things that will prevail.
Well, thank you, Tony. And, you remain a hero to many of us. Want to thank you again for your truth and authenticity throughout this whole venture, and just wish you and Dr. Grady and the whole family the best of luck and health going forward, and look forward to seeing you again, hopefully sooner rather than later. So take care, and thank you for joining us.
Thank you very much, Linda-Gail. Thank you for having me. I really appreciate it. And all the best to you and your family. Take care.
So everyone, that was just a wonderful opportunity to hear it right from the mouth of science, I guess. And you know, I think one of the things that's been most touching for me as I listened to the 60 minutes pod or video that Dr. Fauci just had filmed and released was his ability to admit that as he learned, because you'll remember that right at the beginning of the epidemic, he stood up publicly and said that masks were not a good idea. And he said that, I think, because there was a real concern that hospital masks, the sort of N95 masks, would be needed and would be the sort of minimum standard, and that we would soon run out of them and there would be insufficient of that kind of protective wear for healthcare workers. And it was on those grounds that he sort of decried mask wearing. He now comes out and says, you know, there is new evidence. There's also evidence now that the virus is transmitted from people who are completely asymptomatic. And even before, you know, there's any sense that they might be infected. And so for these reasons, mask wearing is to be recommended around the world. And he was able to say, we learn new truths and then we act accordingly. And again, really, I think an extraordinary, you know, behavior in someone who is so knowledgeable and has walked such a long road of research and science. So William is going to join me now. Hello, William. And we are going to try and answer some of your questions and maybe even create a bit of a discussion here in the next 15 or 20 minutes. So, William.
Yes, Linda-Gail, lovely discussion with Dr. Fauci. I'm just interested, before you go on to the questions, he clearly has a great warmth towards South Africa, and obviously you have worked with him for some time around HIV. Why don't you sketch out some of that for us?
Sure. So if you like, he is the father of the networks, and the networks go back decades. So as you heard, started out with the ACTG, the Adult Clinical Trials Group, and the Pediatric Clinical Trials Group way back. There was also another kind of treatment strategy group and who did various kinds of treatment options. And then the prevention networks came about. Now, these are networks that are funded by his institute, and they run clinical trials around the world. There are these large-scale clinical trials units, and I'm very fortunate to run one of those in Cape Town here. There are clinical research sites associated with those clinical trials units. And then there are these large-scale networks run by really, again, leading scientists who channel protocols, literally like a factory, through to discover new medicines, new drugs, new strategies, and new interventions that can work. So the kinds of things that have come out of his shop, if you like, are pre-exposure prophylaxis, the knowledge around that, the fact that we now use, you know, a pill a day to prevent HIV. All the prevention of mother-to-child programs came initially out of his shop. The notion that we know that we shouldn't interrupt treatment, that we should get people onto treatment and virally suppress them, because when they're virally undetectable, then they are virally untransmittable. That all has come out of the NIAID, as it is known, and it is a multi-billion-dollar industry to find new medications for HIV. But what you heard is it's not just HIV. So when Ebola hit, his organization really found the vaccines for Ebola. He has his own lab. He's been running a lab since 1980 something. And he actually pushes some of these things through his own laboratory. And then there are actual clinical trials units associated with the campus in Bethesda, where the NIH is. And it's just extraordinary to see the incredible passion he has. He goes to the Hill regularly to make a case for more money to come into the NIH in order to create this R&D. And then you heard by his own admission that during the George Bush administration, he was called up to the Hill to say, why is it that people are dying in the southern part of the globe and they're not dying around here? And he had to point out that actually that was all about access to antiretrovirals, and that it was from that PEPFAR was born. And the President's Emergency Fund for Antiretrovirals, for AIDS relief, as it's known, PEPFAR, has saved literally millions of lives in this part of the world. So he is my hero, and I'm sure he's the hero of a great number of people, but he's 79, William. I don't know if you know that. He's 79 years old. And as disturbing is the fact that his family and himself have had literal death threats during this coronavirus. He now goes for power walks with his wife, Dr. Grady, with two, large, bulky bodyguards walking with him. It's extraordinary. The world is an extraordinary place, but that is my tribute to him.
It's interesting in a world where there are not very many heroes that survive scrutiny for any length of time. We live in a world where of anti-heroism, in a sense. And he's so modest in his response, saying, well, we're in a time where people are looking for truth and integrity and clarity, and that he just happens to be there at the time. I mean, it's of course excessively modest. I mean, he has become a repository of so much hope because he is such an unusual figure. It intrigues me that for good democracies to work, you need to have a professional civil service that produces people like Fauci, and that are not in their jobs because they're political appointees or the flavor of the moment or the deputy president's second nephew. And it's still one of the strengths of the American system that it can produce, and someone like Fauci can survive 6 presidents, including one who clearly despises him. It's an interesting aspect of American democracy that still happens.
Indeed. And the other thing that is extraordinary about him is that he has, I think one of the things we've learned about COVID is the parallel with HIV and the need for community engagement. I mean, I think he spoke about that we could have a brilliant vaccine. If it isn't taken up by people, it'll be worth nothing. And so that engagement with humanity is so key to the work we do. And this Tony Fauci has really embraced. He goes back to the days when they used to, throw blood on the steps of the NIH and glue up all the locks into the place. The activists wanting to be heard and wanting to get his ear. And, when you read or watch the movies from those early AIDS days, he was there, he rubbed shoulders with those guys, and he's loved by every single one of them today. So I think that ability, I think it's the Italian, sort of Brooklyn approach where, it's the tough guy meets another tough guy, but mutual respect is really, at the bottom of it all. And then that quest for truth and just science in the best possible ways. I similar to you, I've been intrigued that he has fallen out of favor with the present president of the United States, but I think some of that may be that he's been so sought after, and I think it's about sharing space and I don't know, fame perhaps is what has got in the way of their relationship. But I think he's been, again, a gentleman. He's really continued to offer help. Again, in that 60-minute interview that he was on, I think his phone rang 3 or 4 times and he had to answer it every time. He's recently had to have a nodule removed from his vocal cords because he's been speaking 24/7, you know, and really contributing in the most extraordinary way everywhere he can, including to the White House. So, yeah.
Linda-Gail, the one point that he raised, and it plugs into the point you make about HIV/AIDS in South Africa, the thing about take-up of the vaccine, he's concerned about minorities not taking up the vaccine in the United States. You've gone through that here. You've seen the problems of resistance to taking drugs. What do you think will happen in South Africa? I mean, from the response to the trials that are taking place, it seems that people are very, very eager to participate, but there isn't the same kind of resistance, except for certain groups on social media. What's your view on that?
Yeah, you know, William, I've been a little concerned to see perhaps more activity from the anti-vaxxers on social media than has been the case before. My own impression after doing 20 years of vaccine R&D for, you know, HPV, HIV, TB over many years is that there is a great deal of enthusiasm for vaccination in this part of the world. You know, our EPI program is alive and well. We have really good uptake. Mothers understand that they must get their children to be vaccinated. So on that foundation, I think we're better off than some first world scenarios for sure. But there is no doubt that there's a very strong anti-science, anti-vaxxer movement that, you know, that we have to handle carefully. Heidi Larson, Peter Piot's partner, writes a lot about this, and she recently brought out again some papers along this road that it isn't necessarily useful to call these individuals out, to publicly shame them, etc. The way to go about this is to try and engage, to bring the science home. I think that there are those individuals who kind of sit on the fence and can be persuaded. I think, though, that as we discovered with, you know, the denialist phase here in South Africa in the early 2000s, when we were battling the sort of anti-retroviral mandate, there are professionals in this regard who cannot be persuaded. I think their agenda is one that isn't necessarily anti-science. I think there's another whole agenda on the go, kind of a destabilization agenda. And those individuals, I think, are incredibly hard to reach, but I think they should be ring-fenced off in a way. And we should continue to seek to engage with communities in an authentic way that really brings information home, you know, comprehensively, make sure that people understand the value that they see, how positive vaccination can be, how it saved lives. I mean, we've got some really great stories. We've almost eradicated polio. This is the year that we were able to do that. I really hope COVID hasn't set that back. And obviously there is concern that the EPI programs have suffered because of lockdowns around the country, and around the continent. But, you know, I think we need to think about how we message, how we bring activists and advocates on board who are peers, who can also help to promulgate the value of vaccines, you know, in public health. Of course, you know, the wonderful thing is this is where herd immunity really comes into its own, is that if we get coverage up with enough people vaccinated, even with a partially effective vaccine, then herd immunity can kick in. But when we don't, that's when we get the breakthroughs that we've been seeing, you know, measles outbreaks and so on, that really have been very disturbing, given that those are all preventable conditions.
There's a question here, which I'm going to read to you. It's reflected in a number of the questions, but I'll read you this one. It pretty much sums it up. The infection rate with COVID-19 is lower on the African continent than in Western countries. It's difficult to attribute this only to public health measures. Social distancing in most countries was difficult or frankly impossible. Expected high morbidity and mortality rates in vulnerable populations with TB and HIV never materialized. What are the reasons for that? Why is Africa different?
Yeah, so I think, Tony partially answered that. I think there may actually be more to it. Yeah, I think he's right. It's multifactorial. I think we're going to find that, there are a large number of reasons for this. I would agree with the writer of that question that, I'm not sure that it's been entirely because of lockdown. I think we have seen quite a lot of community transmission, and certainly it's very hard to separate susceptibles and infectious people in some of our communities where clearly transmission has gone on. So, some of the thoughts we've had, and I know you've discussed this with Robin over the weeks that you've been having those webinars with him, is, what about background immunity, for instance? So there are other SARS-CoV viruses, coronaviruses that occur in animals. Somebody else pointed out to me there's also been relatively low infection rates in Southeast Asia. Now, there's incredible contact between individuals and animals in that part of the world. So again, you've got that potential exposure to coronaviruses that may be giving us some kind of immunity. And I think we don't fully understand yet what immunity is. I didn't get round to asking Dr. Fauci, but I'm puzzled why the convalescent virus studies have not done better. That in itself is extraordinary to me. Is that a bad omen for vaccines? Or is it telling us something different? And then, I don't know if you've seen, William, that seroprevalence study done here in the Western Cape now showing a 40% antibody positivity among some populations here in the Western Cape. So, how much of that is actual contact with SARS-CoV-2? How much is some cross-reactivity? I think we've still got a lot to learn about this virus, and, in its early days.
The convalescent therapy thing is interesting. Why has it, what is your view on that? Why hasn't it been more positive response?
I actually don't really know. I mean, I don't know if anyone else has on the webinar, if they want to type what they think is the reason in the chat. I think it's had a sort of a mixed outcome, but certainly it hasn't been a slam dunk. Now, when you hear the results of the cocktail, monoclonal studies where people have actually developed antibodies to the spike, the actual treatment that Trump got himself when he got COVID, that seems to be, much more promising when you look at, the in vitro studies around that. So it isn't clear to me, why so is it about the amount of neutralization that so are we making antibodies that aren't very good neutralizers? In HIV, that is what has plagued HIV. As you know, we make lots of antibodies when we get infected with HIV, but they don't actually protect against HIV itself. And we've been seeking good neutralizing antibodies for many, many years. Finally, we're beginning to see highly broadly neutralizing antibodies that we've been able to then isolate and get back into people. And so this now is the era of prophylaxis with monoclonal antibodies against HIV. And so people will have heard about this study called AMP, the antibody-mediated prevention study. It will read out literally in another month. The study is done. The manuscript is being written, and we'll hear in a month or so whether that monoclonal antibody worked. Now already people are moving beyond a single monoclonal antibody to say probably for durability, for depth and breadth, like antiretrovirals, we're going to need more than one monoclonal antibody. So they've actually made tri-specific antibodies now, where broadly neutralizing antibodies, more than one, targeting more than one part of the virus, are now being put together in a cocktail. And, I think the next big question, which is what I posed to Tony, is will we be able to afford to manufacture these monoclonal antibodies? We know here in South Africa how expensive they are in other disease fields, in cancer, in rheumatology, etc. Are we going to be able to manufacture these monoclonal antibodies in a way that is going to be affordable and deployable? And I believe that, again, Tony's shop is looking into that. So the guys at the NIH, together with the International AIDS Vaccine Initiative, are really looking at cheap ways to make these monoclonal antibodies and get them out in ways that we would be able to afford them. So that, I think, is the next era of prevention. And it's potentially, as he was saying, one of the answers for COVID-19 as well. My concern is those very elderly people who aren't going to mount a good vaccine response simply because their immune systems are now senescing. Could we passively transfer protection to them in a monoclonal antibody? That seems very plausible. The question then is going to be, will we be able to access them from this part of the world simply because of cost and availability? And that's going to come back, as he was saying, to manufacturing. If these things can be manufactured really cheaply, then they shouldn't cost 20,000, 30,000 Rand a shot, which is what, unfortunately, we are paying for a lot of these monoclonals.
You've been watching this or experiencing and working with us now during this entire pandemic. How do you see it playing out now over the next months? You've been watching the 7-day moving averages. What does it look like to you? Are we going to have a second wave?
Yeah, so this is where Robin Wood, who's sleeping in the background right at this moment, comes into it. I would love to just let everybody know that every day we look at these figures first thing before breakfast. It seems to me that the thing that's happening at the moment, and what he reports to me, is the Orange Free State and actually the Northern Cape are where the hotspots are currently. And it would appear that they're sort of in their first wave, if you want to coin this terminology of waves. The rest of us are kind of plodding on. Definitely there are these little outbreaks. You all heard about Tin Roof, and there have been other events, that cause a blip on the horizon. But if you look at the 7-day moving averages, then we're all plodding along. And I suspect that's sort of what it's going to look like. I am concerned about prevention fatigue. We saw that, we've seen that in HIV. We haven't been able, and I say this again, we haven't been able to get the incidence down in certain populations in this country because of a number of factors. Prevention fatigue is one, but obviously also we just haven't had the right prevention tools to deploy to people. And that's my concern, is how do we keep a consistent level of, an eye on all of this? How do we keep this up over a long period of time? Even more worrying I would be if I was living in an island state like New Zealand or Australia. I mean, how do you keep that going for months and months if you don't have a vaccine in the mix there to be able to kind of move the epidemic along? So I'm afraid I don't call out. I don't have a crystal ball, so I don't know. But the way it looks at the moment is that, we're having some transmission, but it's fairly low level transmission, and it's probably going to go on like that, with perhaps occasional hot outbreaks or super spreader events. And hopefully that promise of a vaccine will come sooner rather than later, so that we can, bring an end to all of this and try and get back to some kind of normal or near normal state once again. I'm dying to travel. I'm sure many are.
We still have some summer ahead of us, which must also be an advantage to us.
Yeah, agreed. I think, I'm going to say this again, and this is our mantra: fresh air is my friend. We can do a lot as long as we're outside and it's in a well-ventilated space. And so, yes, it is very much to our advantage now in the South that we're moving into the summer months. I'm very concerned about the North, and 83,000 new infections on a day is unbelievable. It's hard to wrap your head around that.
Linda-Gail, we're running out of time. If you don't mind, I'll hand over to Jaco van der Sant from PPS to wrap it all up. It's always lovely to talk to you. Thank you for such a wonderful interview with a man you clearly admire and with whom you have a lovely relationship. Thank you.
Thanks, William. Thanks, Jaco.
Thank you, William. Thank you, Prof. Bekker. Yeah, from my side, thank you very much. That was fascinating to listen to you. We were blessed with your insights. It was lovely to hear from Dr. Fauci. But I must say, you make us proud to have someone of your caliber in our own midst. So that was wonderful. For me, really 4 things that stood out. The one is just our healthcare workers in the front line. Absolutely awesome what you are doing. Putting yourselves at risk every day to save lives and help those around you. So thank you to all for that. You said something, Prof, that resonated with me, and that's a safer environment. So we can't be safe completely, but we can do the simple things to make just us around safer. And that wearing masks, social distancing, personal hygiene will go a long way in keeping the spreading low. Vitamin D, I could see how both of you responded to that topic. In SA, we are blessed with sunshine. We've got a wonderful country, and I think it's time that we all spend more time outside. Yeah, there's not scientific evidence yet, but why not take a chance and get enough vitamin D? I mean, the last thing is, I think in this time, something that stood out for all of us, we're all looking for that truth, integrity, and clarity. There's so much rumor and stories on a daily basis. You get all sorts of WhatsApp messages, and there's just a lot of rumors going on. And it's good then just to pause a bit, sit with experts, listen to your views. And I think we all just want that reality check every now and again, and say, let's be real about this. It is a problem, and how best to safeguard ourselves. So just from PPS Health Professions Indemnity, healthcare workers is really at the heart of what we do. Thank you very much for your time. Thanks to all the participants tonight. It was a pleasure having you. William, as always, working with medical brief, what a privilege. Thank you very much for the opportunity. All right. Thanks, everyone. Be safe out there. Be blessed.
Thanks, Jaco. Thanks, William. Take care.
Thanks, guys. Cheers. Bye-bye.
Well.